pleasure to introduce Sean Greminger. How many are aware of the National Alliance of Healthcare Purchaser Coalitions? Very good. HBCH is one member. Sean will talk briefly about the composition of the National Alliance. I'm proud to serve on the Board of Governors, and Sean has been our new CEO, finishing up his second year, I think, if I'm not mistaken. So I asked him to talk about what the National Alliance is doing in this space, taking a national perspective. We're very active in this. So, and Sean got in at 3 o'clock in the morning, so he's not as sharp, you know. I'm
going to do my best. I was able to get a good night's sleep after I did get in at 3 o'clock in the morning. Flying out of Reagan National is not as much fun as it used to be, if it was ever fun. Thank you very much, Chris. Very pleased to be in Houston, which I consider almost like a hometown. Both of my parents grew up in this area, and actually I'm really pleased to be invited down here because after this I get to drive down and see my aunt and uncle in a tiny little town called Seadrift, Texas. Anybody know where Seadrift is? Oh, yeah. A couple of you, all right. Great hunting and fishing down there. We're going to go fishing tomorrow, which I'm really excited about. So thank you again. Really pleased to be here. Chris asked me to cover a lot of topics in a limited amount of time today. So I'm going to be talking relatively quickly and kind of going over things at a high level. We're a lot to talk about. I'm with the National Alliance, and we're here to help. And there's a lot that the National Alliance hopefully does for HBCH, Dallas-Fort Worth Business Group on Health, another one of our proud members, and more than 40 other coalitions around the country. But also you wanted me to dig a little bit into the drug spending on the medical side, in particular through purchasers. I'll talk briefly about policy and how you as employers can hopefully help us. And then Chris has always been very good about sort of saying, hey, we need to have like immediate action steps. Like what can we do? Don't just talk about the problem, talk about some of the solutions. So I'm going to give you a couple of ideas around solutions and then offer a few other ways that we could potentially work together. Real quick, before I get into the hospital side of things, if you think you're getting screwed by your PBM on the pharmacy benefit, do you believe you are paying more or less for drugs in the medical benefit? Anybody want to say less? Have any guesses on less? Okay, good. You guys are a well-educated audience. As badly as you may be getting screwed by your PBMs, I promise you are getting screwed worse on the medical side, and I'm going to talk a little bit about why that is and potentially what you can do about it. So, National Alliance. It sounds like most of the folks here know about us. I've recognized many faces, so thank you again to Chris for having us talk about the work that we do. 40 plus coalitions around the country, thousands of employers. I think last guess we had was 12,000 employers, but we haven't asked that question in some time. But we did do a survey of all of our coalitions earlier this year, and we found that incredibly, the National Alliance actually represents, our 40 coalitions represent enough employers that we've got about 90 million covered lives across the country. So actually a majority of the commercial market is represented by a coalition that is a member of the National Alliance. And something like $850 billion in annual spend. That's based on just sort of averages. So we are a sort of small but mighty organization. There's only 10 of us in DC. But when you take all of our coalitions together, you're probably talking about 100 plus staff and a real kind of vigorous nationwide movement that we're trying to really change healthcare just across the United States. So the National Alliance produces a huge number of resources, and if you have not had the opportunity to take a look at those resources, blame Chris. No, I know Chris does a great job of getting this stuff out.
I wish there was a QR code here, but every one of these resources, if you go to our website and you look under resources and you look under pharmacy or pharma or whatever we call it, right. They're all there.
They're all there. And we continue to spend an enormous amount of time on drug spend because we know it's the number one issue of concern by employers and purchasers pretty much consistently year in and year out. So you can see we've done a lot of work in the high cost claims space. and I'm going to talk a little bit about that. And the leading driver of higher cost claims is oncology, and most of the cost of oncology care goes into the drugs and to the administration of those drugs. But we've also spent a lot of time on sort of ways to address PBM misalignment, et cetera, and we intend to continue to do that work over the next several years. So you can see just a smattering of some of the resources here. As you said, they're all available up on our website and free to any coalition or any member of a National Alliance coalition. So I want to get into hospital pricing, particularly on sort of the markup that we see, in particular among hospitals and health systems in the commercial sector. So it starts with vertical and horizontal consolidation, right? This is how hospitals are able to leverage their mass to be able to drive up their prices across the board, but particularly to be able to drive up the prices in sort of price arbitrage, buying at whatever price they can buy it at and selling at a much higher price. So the United States has a highly consolidated, or each market in the United States is highly consolidated. You can see the top left graph is from the Healthcare Costs Institute. Houston, to your guys' credit, is less consolidated than average. You can see that little kind of orange box there. But you are still considered a highly consolidated market. Anything that's sort of in yellow or higher is problematic. That's 90+% of metro areas in the country. Anything that's in orange is considered highly consolidated, and anything in that red, you basically have a monopoly. So Houston is a highly consolidated market, but maybe not quite as bad as some others. I would say, if you know the name Zach Cooper, economist at Yale, he spends an enormous amount of time focusing on this issue. There is a very clear correlation between hospital consolidation and how consolidated a market is, and the prices that are charged in that market. It's not exactly a direct line, but it's a very clear line. There is, by the way, zero correlation between hospital cost and quality, which I think all of you probably understand. It is interesting doing this conference here at Texas Medical Center, the largest agglomeration of hospitals in the world, all in one place. And I stayed at the Marriott across the street, and I was looking at the beautiful gleaming buildings of Methodist Hospital, and I was thinking, what a nice hospital that is. Guess who paid for it? The other thing, of course, is not just we have horizontal consolidation, hospitals buying other hospitals, but we have hospitals buying everything else, right? And you can see here the percent of U.S. physicians employed by hospitals or corporate health entities, so this does include private equity-backed companies, et cetera. Just since 2019, we went from 62% to 77%. If you go back to when I first got started in health policy in the early 2000s, it was less than 50%. Today, the American Hospital Association likes to say they represent more physicians than the American Medical Association, which says something. So the consolidation creates mass, which allows them to do things. And so what do they do? You, again, I think probably understand this, but I'm going to kind of quickly walk through it. You think about how hospital systems price their services. Not only are the services themselves more expensive when delivered in a hospital than they are delivered in a non-hospital sort of outpatient sector, but the price that you are paying for the underlying drug is substantially higher. Also, by the way, if the drug is being infused, you're paying a whole lot more for the infusion than you would be if you were paying for it in a physician office, an outpatient independent physician infusion center, et cetera. But these are just some examples. This is all pulled from AHIP. So this is not the underlying price of the drug, right? I'm going to go to Keytruda because it's one that I know pretty well. There's what you pay for Keytruda, right? And then there's the markup. This actually shouldn't say what you pay for Keytruda. There's what the hospital can buy Keytruda for, put that separately. And then what a physician practice could buy Keytruda for, which is going to be roughly similar. The physician practice is probably going to pay a little bit more. And then there's the markup that that provider inputs into the price of that drug. When you're buying Keytruda from a hospital, you're paying a almost $11,000 markup for one dose of that drug. It's not the drug. It's not the drug, right? It's just their markup. It's just straight profit. The same goes for Darzalex, Lucrentis is slightly lower. But you can see these are just some examples. The area that you are paying the most, not surprisingly, for, in terms of price markups, are on the most expensive drugs. There are things you can do about this. It's hard, right? It's really hard because, going back one slide, this is how consolidated they are. And many patients are getting their drugs infused or through on the medical side. But there are ways that you can try to avoid some of these really just atrociously high costs that are adding absolutely no value to your patients, to your covered lives, but are an enormous area of profit for hospitals and health systems. I've managed to take my entire 340B talk track and put it into one slide. So I spent a lot of time talking about 340B, my favorite program to hate. And I literally have done hour-and-a-half long presentations on this. I'm going to keep it to about 2 minutes. Show of hands in the room. Who thinks they know 340B pretty well? Like, pretty well. Who thinks they know, like, 340B a little bit? They kind of understand what it is. Who thinks that 340B is just a series of numbers and a letter? All right. So 340B, in very brief, is a drug discount program, a drug pricing program that allows certain, what they call covered entities, so community health centers, certain other kind of safety net organizations, and some hospitals, and at this point it's actually a majority of hospitals in the country, to purchase drugs at a statutory discount. So they actually are able to purchase drugs cheaper than anybody else, except maybe Medicaid. And then the idea, when the program was created in 1992, is that by purchasing drugs at a lower price and selling them at a higher price, that would create revenue for that community health center, that hospital, et cetera, to then be able to use to provide free drugs to uninsured people, to be able to open up access points in low-income uninsured communities, et cetera, right? Like, that was the idea. They're safety net organizations. You can see on that sort of top right graph, the program has grown from $2.4 billion in 2025 to, this one starts in 23 at $66 billion. We have 2024 numbers now. It's over $75 billion. It is the second largest drug purchasing program in the country after only Medicare Part D. So think about all of the Medicaid patients in the country, all of them, and all the drugs they buy across all 50 states and 5 territories in the District of Columbia. All of that, 340B is bigger than that. And by the way, most of the 340B purchases are not for uninsured patients. They're not for Medicaid patients. They're your patients. They're covered lives by employer-sponsored insurance in the commercial market. So the hospitals buy low, and then they sell at those kinds of markups. And then what do those hospitals do with that money? Well, one of the problems is we don't really know because there's no transparency or accountability into how hospitals are actually using 340B revenues. One of the things we do know, and I don't have this on this slide, is that while that chart has gone up like this, the amount of charity care provided by hospitals and health systems in the United States has actually declined over time. Over the same period, it's actually declined by about 20, 30%. The biggest problem for employers, the reason that employers should care, is that you don't get your rebates when the hospital buys the drug through 340B. So right now, you guys understand PBM rebates better than I do probably. We think rebates are broken. We would rather just get rid of them. We would say let's just pay based on lowest net cost. But whichever way you think about it, we are, ultimately you're contracted with the PBM. They negotiate lower prices based on rebates. We get some of or all of, depending on who you ask. Those rebates pass on to us. So you're paying a post-rebated price. When the drug is filled through 340B, the PBM does not get a rebate from the manufacturer. They do not pass on a rebate to us. You are paying full price for those drugs. As that program gets larger and larger and larger and more hospitals are participating in 340B, by the way, all the big hospitals that are across the street over here, just about all of them are in 340B. At one point, it was just Ben Taub. It was just Ben Taub. It was the hospital that we all think should be in 340B. Now, it's Methodist. It's Memorial Hermann. It's not HCA, because for-profit hospitals can't participate. But most of the other big sort of quote-unquote not-for-profits participate in the program. Because they get the discount, you don't get the discount. It's a one-to-one correspondence. So the growth in 340B is posing real challenges for employers and purchasers. And there's things that we're trying to do in policy to try to change that over time. All right. So Chris asked me to briefly talk about sort of the policy landscape. our previous speaker sort of said, if you go to Capitol Hill or you're working inside the Beltway, I've lived inside the Beltway for 20 years now. Yeah, the status quo, like if you're going to place a bet in Vegas, like you should just bet on nothing happening and you're going to win 95% of the time in DC. But every so often you'll lose, and that's what we're trying to push for, right? There are certain things that we want to get across the finish line. The first one is PBM reform. We can talk more over lunch about what this looks like, but there was really very strong, not perfect, but very strong PBM reform legislation that was, to use sort of the a football analogy, we were on the 1 yard line, right? It was 4th and goal at the 1. Almost exactly a year ago. It was in December. I want to say it was like December 10th. Last year, this was bipartisan, bicameral, means House, Senate. Everybody was on board. We were going to pass this damn bill as part of a government funding package. And then Elon Musk sent a tweet. I wish I was joking. This is literally what happened. He sent a tweet and he was like, this bill is too big. And Republicans on Capitol Hill were like, oh, it's scary. And so they pared back the bill and our PBM reform legislation got put by the wayside. We think there's at least a chance that we can get it done this year. We think there's a chance we can get it done, right? It's at least a possibility. When I say this year, I mean maybe before the next government funding runs out at the end of January. We could talk more about the legislation, but it's a big push, and it would actually be the most meaningful PBM reform legislation we've ever seen at the federal level. A couple of other issues that we are pushing on, the Patients Deserve Price Tags Act. This is legislation that would codify the hospital price transparency and the transparency in coverage rules. It would impose more penalties for non-compliant actors. But most importantly is it would clarify something that we believe to be true right now, which is you own your own claims data. We believe that we believe this has always been the case, but the Consolidated Appropriations Act passed 5 years ago said you own your own data, or at least it said you can't have any contracts that have gag clauses that keep you from getting access to your data. The carriers have not generally been terribly supportive of that fact, and so they continue to withhold data from employers. I think all of you have good stories about challenges getting access to your own claims data. This legislation would basically say full out, no, it's yours. Nobody can keep it from you. So we think it's really good legislation. I don't see it passing between now and January, but I think we could see it in this Congress. And then we are also pushing on federal 340B reform, and again, we can talk more about what that looks like. I sort of put that guy was supposed to be like third, because 340B it's a longer term play. I think we are on 340B in the kind of the dialogue in DC about where we were on PBMs 4 or 5 years ago. We're still educating policymakers about why the program is such a problem for the commercial market. I want to just ask all of you, and Chris and Marianne have been fantastic about this. We need employers to be more engaged in policy. And I know how hard that is. I know that, I get the ask all the time, can you get an employer to come and talk on the Wall Street Journal about how they support blah, blah, blah? And I'm like, no, you're crazy. They're not going to do that. Or can you get them to sign this letter saying we support PBM reform? And I'm like, no, it's not going to happen. They're not going to put their name and logo on a letter like that. There are things that you can do, though. And I want to encourage you to think about what you can sort of get away with within your company. A couple of things. Come to DC. We do fly-ins. We did 3 of them this year. We had a bunch of employers come. You don't have to put your company's name on it. You don't have to do a big letter. You don't have to all you have to do is come to DC and talk about what your experience is. Talk about the challenges you're having getting your data. Talk about the challenges you're having with working through with PBMs. Talk about just prices are too damn high and we need help, right? And then this is where I have, remember, you own the problem, we can own the solution. You don't even have to be a policy expert. You just need to be a voice from the employer purchaser community saying, Houston, we've got a problem and we need help. Go to Austin, work with Chris, work with Marianne. Go to Austin and advocate on behalf of your interests in front of legislators. Write an op-ed. That's a harder one, but even though that one does not have to be, this hospital is bad, or that employer, or that carrier is bad, or that PBM is bad. It just has to be, we're paying out the nose. It is increasingly hard for us to continue to provide high-quality healthcare to our employees and families, and we need help. That's all the op-ed has to say, right? Get a story, talk about what you're experiencing. I do want to do one quick policy shout-out to the great, small but mighty state of Vermont. Vermont is got to be like the anti-Texas, right? Let's just stipulate politics and size and everything are very, very different. But Vermont, the state, health plan actually started to realize and started to look around and looking at RAND data, which is data that we use all the time, and they recognized they had the highest hospital price markups on drugs of any state in the country. And it wasn't even close. It was like 50% higher. The average price markup for hospitals for prescription drugs was 700% in Vermont. And they dug into the data. They got together with Chris Whaley, who's a researcher at Brown University, who we work closely with, and they looked at the price markups in each hospital. Vermont's a small state. They've got a lot of small rural community hospitals. They've got a couple of very small systems, and they've got the University of Vermont. Big hospital for a small state. Most of the hospitals, their markups were 50%, maybe double their acquisition cost, double ASP. Excuse me. University of Vermont was 850%. So they're buying a drug and then marking it up 9 times and selling it. And not surprisingly, that was literally bankrupting employers and purchasers. It was starting to bankrupt the state. And credit to some of the really strong leaders in Vermont. They actually passed a law, H.266, that limits hospitals to no more than a 20% markup over ASP for drugs in the commercial market. Can Texas get there? Not today, not tomorrow, but someday. And I think this is a real example of real leaders sort of saying, like, we can do something about this. This does not have to be the reality. Not surprising, the University of Vermont is suing the state. We'll see how it goes. All right, so I wanted to spend a minute talking about immediate actions that you can all take. And I am not the best expert in this space. We have excellent experts at the National Alliance that we work with who help employers every day sort of manage high-cost claims. Anyway, this is a very detailed slide that sort of shows what you, just in the infusion market, how much a site of care redirection can make a difference. So you're paying an enormous amount for infusions in hospitals. Does anybody disagree with that? Does anybody say, like, no, actually, infusions in hospitals are cheap? No, they're not. To the extent that you can either design your health plan to substantially disincentivize people to use hospital-based infusion, or in some cases, if you just have a really single or a couple high-cost claimants that are receiving Keytruda in the hospital, and you can move that to a different site of care, the amount of money you can save is measured in the millions of dollars. So I'm happy to connect you with folks who can be experts on this, but look into your data and look at your infusion costs. Look at where your patients are getting their infusions. And each time you can move that person from a hospital to a community-based or a home infusion, the patients love it. I mean, I'll tell you, I've talked to the patients generally. Would you rather get your drug infused at home or at a clinic a couple of miles from your house, or would you rather drive all the way down here to Methodist and get it done down here? Most patients, 95%, are going to be like, I would rather get it done at home. And you will be literally saving, 75 to 80% off of what you're paying right now. A separate one, this one's a little bit more controversial, but I think employers have to start being aggressive about this kind of stuff. White bagging. There's also there's brown bagging, there's clear bagging, there's gold bagging. I don't fully understand all of them. But white bagging is probably the one that's best understood and generally, not surprisingly, hospitals hate it. But you actually can, as an employer, really aggressively pursue this. So you're saying, if there is a specialty drug that typically you are purchasing through the provider, through the hospital, you can design your plan. You can use something called a J-code lockout if you want. That says, no, actually, we're going to have that specialty drug purchased through our specialty pharmacy, through our pharmacy benefit, and then we're going to have them ship that actual unit, the actual physical unit of that drug, to the infusion center, to the hospital infusion center as necessary, and then they will still, you'll still have to pay the hospital infusion cost, but you're buying the drug on your own pharmacy benefit at, half to maybe a fifth of what you'd be buying it through the hospital. Now, they're going to push back and they're going to say, well, I don't know, I don't trust it. How do we know that it's been safe and the whole thing? And I'm like, I've got a lot of things to say about CVS Caremark and Optum Rx, but I'm pretty sure they know how to buy drugs and physically move them to a place and keep them safe. This is not some dodgy company. So we're saying literally just buy it through your PBM, buy it through your specialty pharmacy affiliated with your PBM, instead of buying it through the hospital. It can be done, it has been done, and it can save you millions of dollars. And again, happy to chat with anybody, not really to answer your detailed questions because I won't have the answers, but to connect you with the right people who will have answers about 2 immediate actions you can do to try to deal with some of this problem. All right, I only have 1 minute left. A couple of things that I wanted to flag that are interest, certainly for me, and I hope would be interest for the employers and purchasers in the room. We have just recently this year launched what's called the Pulse of the Purchaser Research Institute. We've been doing an annual survey of employers for years called the Pulse of the Purchaser Survey. This is an opportunity for us to gather more granular and detailed information from employers about your perspectives on critical issues. It's an opportunity for you to engage with researchers. One of the first projects we're planning on doing is a really exciting one. The client is a small biopharmaceutical company that has a new product in the mental health space. And actually they're using psychedelics. And they want to know, will this fly in the commercial market? What will this look like? What do employers and purchasers think? I think it's a fascinating question. They want to know because they want to figure out how to sell, but also it's going to provide information to the National Alliance and to all the participants who participate in this research to understand what are other people thinking about this particular issue. You can learn more on our website. We actually do have a QR code on this one. So you can take a look and see if you'd be interested in becoming part of this panel. You get more insights in terms of what other people are doing. And actually, because we are bringing in paying clients to help fund some of this research, some money actually flows back to the National Alliance and to your regional coalitions. So it also helps support the coalition movement of your coalitions. And then the last one, and there's a lot we can talk about this, and I'm happy to talk over lunch. We talked about you owning your own data and getting access to your own data. One of the challenges we found is that every employer's data is housed in a different way by a different vendor, right? The carrier's got it, the TPA's got it, maybe you hired your own data warehouse and that's all good. But first of all, it's hard to work with your carrier or TPA. If you're reliant on your TPA to house your data and give it to you, good luck. If you're reliant on your broker to house your data and give it to you in a way that's usable and not have them tell you what you're supposed to do with it rather than actually just give you the information, good luck. We've formed a collaboration with the Healthcare Cost Institute to create a sort of nonprofit, employer-driven claims collaborative. Think of it as a data warehouse that will aggregate claims data. Well, you'll be able to house your own claims data in a safe place at a very low cost, ideally free. We're still working on that. You have access to it whenever you want. You say, I want my data. We say, great, it's right here. You gave it to us, it's yours. We do not withhold data from anybody. And then we'll be able to, as more employers get involved, we'll be able to aggregate data across markets, across industries, across the country, and actually be able to use this to drive research, to drive insights and analytics, et cetera. It is absolutely free to sign up, and certainly free for you to kind of put in your data. We just kind of soft launched it a couple of months ago, last month. We will be bringing in early adopter employers in January. Actually, Dan Burke from Turner Industries. Is Dan here?
He was registered. I didn't see him here yet,
though. Right. Dan has said that they want to put in their data. The city of Plano is putting in their data as early adopters just to sort of get this going. And by middle of next year, sort of late next year, our hope is to be able to bring in data from any employer that wants to participate. And again, happy to talk more about that.
Any question for Sean while he's here? He's going to be here. Any question? Ann.
On the white bagging, many states have, in fact, passed bills, anti-white bagging. Do you guys have a plan on how to combat that?
Yeah, I mean, yes and no. I mean, our plan is to help kind of try to educate policymakers to see whether we could repeal those laws. I don't know. I don't think Texas has passed an anti-white bagging law, but I could be wrong. And if they have, we should talk more about it. And certainly to try to stop them from moving forward in other states. You know, the arguments used by the hospitals they're not going to go up and say, we hate white bagging because it takes money out of our pocket. They're going to say, we don't like white bagging because we think it's sketchy and that, that people could get hurt. And I think we just have to be able to sort of explain why it's not a problem. There is the original idea of this was something called brown bagging, which is, I think, a little bit sketchier because literally it would make the patient go down to the pharmacy, like an infusing drug, right? Like a specialty drug. To go down to the pharmacy, pick it up, and then like take it down to their clinician and have them infuse it, that I think understandably, like there is kind of a real sort of chain of control kind of question. But white bagging, that doesn't happen, right? The drug literally goes from the manufacturer to the specialty pharmacy to the infusion center. It saves us a ton of money, and there's really no reason why anybody should oppose it other than hospitals just don't like to lose revenue. Or they could just lower their damn price, right? Like that would be another option. If we just said like, hey, like we can purchase, and theoretically one could do this idea of called clear bagging, just be able to say like, look, we can purchase this drug for X amount at our specialty pharmacy. If you're willing to sell it to us for that amount, then great, we won't do this. It's actually a little bit more complicated and we'll avoid the complication.
Great job, Sean.
Thanks, Jim.
One strategy that one of our employers is doing in this regard is actually building price caps into their summary plan document. So you mentioned Keytruda. Hey, you know what? We'll pay you a fair price, but right in the plan document, we will pay a maximum of $15,000 for this drug. And we've seen it at 30, we've seen it at 90, month after month after month. And it seems to be very effective. So they started out with 7 drugs, now they're expanding it to 20. So, but it's something that's kind of under your control. And guess what? The hospital is going to just take it and run because they don't. We're finding 95% of the time.
Wow.
Just accept it and move on.
That's amazing. I love that. And this, you've seen this with one particular employer, or you're starting to see it?
Well, it's expanding to others.
Okay.
Right now we see one that's doing it.
That's awesome.
So just through HBCH, the Pulse of the Purchaser Research Institute will be putting that out next week. Need some folks to sign up by the sometime in December here. The research collaborative, the data collaborative is really important. One of the things, the National Alliance does these surveys. One of them was, do you have access to your data? And I discussed this with Sean, and 60% or 70%, oh yeah, we got full access to data. I think most employers don't know what full access to data means,
Right.
because their health plan or their consultant warehouse is providing data. There's like 185 fields. You may get 30, 40, but to really do something, you need the full data set. So we'll be focusing on that in 2026. So thank you so much.